Hi, good evening, everyone. I'm Mariam Masoni from the Film Society, and I want to welcome you tonight to Art of the Real, to the Eleanor Butte Monroe Film Center, and to the Film Society of Lincoln Center. We're very happy to have you here. A couple little housekeeping things before we get started. This September is the 50th New York Film Festival. It's been 50 years, and we've been celebrating by having weekly screenings chronologically from the first New York Film Festival, films from each film festival. And tomorrow night, for your information, we are showing Hoop Dreams, which in fact was the closing night film in 1994, a really spectacular documentary about young men trying to make it in the world of sports and how they get through there. Filmmakers Steve James and Frederick Marks and Peter Gilbert will be there tomorrow night, as well as one of the film's subjects, Arthur A.G. And if you've seen the film before, you'll really want to see it again and to talk with Arthur about where he is now. Also, the film will be introduced by Baron Davis of the New York Knicks. So if there are any basketball fans out there, you'll know of whom I speak, and obviously I'm not. But he will be there too. It'll be a really exciting evening, and it's tomorrow night. And also, you can come back and check every week of the different films that we're showing as we count down to the 50th New York Film Festival. Also tonight, we are really excited to welcome Fandor as a sponsor of Art of the Real this month and next month. You should have all gotten some free trial offers, a little card or something that you have, so that you can go online and do some streaming and things. We welcome you to do it and to take care of their trial offer. I think I'm going to do it myself. You'll find a lot of fabulous films to watch. So we welcome them. We thank you very much for what you're doing. Also, after the screening and after the Q&A, because there will be one and you're going to want to stay, you can take your Art of the Real stub for some discounted food and drinks and indie food and wine, which is up in the lobby. And it's a great place to be to continue the conversation that we're going to start tonight, that we're going to start about the screening of Money and Medicine. Roger Weisberg, the director, he's been documenting the challenges that are facing healthcare in the United States for a long time now. He's also shown a number of other kinds of documentaries at the Film Society. We've known him for many, many years, and we're very happy that he is here. In fact, speaking of healthcare, about 4 years ago, I think in 2008, Roger was here with Critical Condition, which really talked about the uninsured and what they do about healthcare. And tonight we're really talking about, cost versus quality, or keeping costs down and keeping quality up. It's going to be really exciting, and we're going to have a really interesting Q&A. But to get us started, because we do want to get the film started, it's my great pleasure to welcome once again to the Film Society, Roger Weisberg.
Thank you so much. Thank you all for coming. Thank you, Marion and the Film Society, for the honor of being able to screen Money and Medicine at this beautiful theater. I want to make sure I thank our foundation supporters, without whose commitment and vote of confidence these films would never be possible. And to the list, I also want to thank Steven Segaler and Julie Anderson and my colleagues at WNET, which is the presenting station for Money and Medicine on PBS. This film is actually the 31st documentary that WNET is presenting on PBS. This time it'll go on September 25th, and I could not ask for better collaborators and supporters than I have at Channel 13. Most importantly, I suppose, in terms of collaborators, are the people who really made the film happen, and that includes the editor, includes the cinematographers, the sound recordists, the graphic arts designer, the composer, the sound mixers, my production assistants, my production managers. Most of those folks are here in the audience. So if you like what you see on the screen tonight, they're largely responsible for what you're about to see. And if you don't, blame them instead of me. The other folks I need to thank are some friends. Some of you are such loyal friends that you've seen this film many times and are here tonight, even though I've told you that nobody should ever have to watch one of my films more than once. So thank you for being such good friends. And last but not least, we're really excited tonight that Dr. Brent James is here with us. He appears in the film, and he'll join me afterwards to field your questions. I think you'll agree after seeing the film that he's one of the really truly visionary leaders trying to reform our embattled healthcare system. And David Leonhardt wrote in the cover story in the New York Times Magazine that if healthcare is going to change, Dr. Brent Jane's ideas will change it. And I would only like to add to that sentiment that his ideas are not theoretical and abstract. He's been applying them for decades and teaching the rest of the country and the world how to improve quality and lower costs at the same time. So I'm sure that you'll have questions and things to discuss with him afterwards, and we're really excited. He flew down from a meeting. He was at the National Academy of Sciences Institute on Medicine meeting today in DC and came down especially to be with us tonight. So thank you all for coming. Enjoy the film, and we'll look forward to talking with you afterwards.
Roger. Doctor. I think we have more than one doctor in the house tonight, but
I think we have a few.
yeah. Have a seat. So there are probably lots of questions out there, but I'll at least start with one to get us started. And I'm just going to jump in with the particular. There were lots of like very specific things that were hitting me as I was watching this again. But I want to go to the doctor. I think it was at UCLA who had the aneurysm, and the procedures that they did on him. And you may not do it on some people, but they found it on him. And I just wonder, and I don't know if either you can't answer it because I'm just wondering in my head if they would have done the same procedures in the whole exactly the same way if you were not a doctor there, if it were just a regular person, if it would present itself differently. And I mean, that's a specific thing. I also wonder if in Utah if the same procedure would have been done if it were a doctor. And it's the question you can really talk around it, the idea of, do individual cases change this idea of what the statistics say?
Let me just jump in, and then we'll get a real doctor's more clinical answer to that. But I think the most critical thing for Dr. Brown was close proximity to a major academic medical center. He told us that the weekend before he was bicycling in the Sierras, and that if this event had occurred there, that he surely wouldn't have survived. He wouldn't have survived to even make it to the hospital. But he was in his office across the street from UCLA Medical Center, where they had invented those platinum coils and that procedure that ended up saving his life. But now that procedure is widely disseminated, and hospitals all over the country are doing it.
Exactly right. I have consulted on cases where we routinely do those within Utah at our hospitals. It's a procedure. You don't have to be a physician. It's a procedure for everyone. Fairly routinely. The question is indications. When's there really a benefit? When should you be doing it? It's also, can you get that catheter into the actual aneurysm? But yeah, we do them routinely, and they are life-saving. You see, it's not a matter of avoiding it all. It's doing it when it works and trying to not do it when it doesn't work. And you can't get perfect answers. I think of it as
Right.
setting the needle. You just move the needle.
Yeah, and of course, in a case like that, it was this very serious thing that kind of presented itself right there, as opposed to some of these other cases, for instance, talking about finding cancers and things, but at what point do you act on it and do you not, which is a little more fungible, I guess.
Oh, yeah.
So let's see. Yes?
Staying on that point, who gets the CAT scan when they present with the worst headache of their life?
So the question is, in case you can't see it, who gets the CAT scan if they present with like the worst headache they've ever had in their life?
We call them indications. There's good science behind it. You're able to identify, usually from a history of physical, from those physicians' eyes, who is likely to have a benefit and who is not likely to have a benefit, you see. So an awful lot of our work is around what we call indications guidelines. When should you do it? When shouldn't you do it based upon outcomes? Now, they're not black and white. There's a little bit of gray. I have to tell you, if it were me or if it were one of my children, appreciating the dangers inherent in this, I tend to be a little less aggressive unless there's a clear indication of benefit. And when there's an indication, we do it. Yeah, his headache, we didn't get a full clinical presentation, but it's very clear that he had indications that he should get a CAT scan. This is when we clearly do it.
And one of the reasons we wanted to include his case in the film, and his was the only story that we told in the past tense, this was an event that actually happened months ago that we recounted, was because we didn't want to convey the message that you should never do a CAT scan for a headache or a head injury, and that these tests can in fact be life-saving. And the question is, when do you do them? And so the routine head injury for the boy who is presenting with no neurological symptoms is a lot different, for example, than was Dr. Brown.
And I guess, yeah, okay, go ahead. I'll just try to repeat basically what this question was, which was, how long do you follow up on patients where using the indications, if, for instance, there's not anything aggressive done at the moment? Do you keep following up with these patients?
It varies based upon the specific condition. One of Intermountain's real advantages is that we've been investing for decades in good data systems so that we can tell what happens. The truth is I have follow-up data sometimes 30 years, long time. They attrit over time. You lose people over time. You can't find them. They move, things like that. But pretty good data for long term. Now, it depends upon the specific condition. It's a long-term investment, by the way. You just keep pouring a relatively small amount of money into it so that you can see what actually happens.
But I'm sure he also relies on randomized controlled trials and the gold standard for trying to measure effectiveness.
Yes.
Yeah, this is, I suppose, primarily for Mr. Weisberg. The movie was phenomenal, but I was struck by the fact that you didn't go near the catastrophe of the U.S. healthcare system, which is 60 million Americans without access to even basic care. And I'm just wondering why you didn't touch on that. And, again, the 60 million Americans who cannot access even basic health care, many tens of millions of other Americans who have something called privatized health insurance. When they need health care, they find the insurance is woefully inadequate. So I'm just wondering why you didn't.
Well, yes, I'm sorry, and I'll just repeat that, which is this viewer is wondering, well, she liked this film, why Roger did not really address the healthcare crisis in the United States. Of course, you've addressed the uninsured in films and things, but talk about why you didn't address that in this film.
Well, arguably we bit off even more than we can chew in trying to address the cost crisis. And the cost crisis is really the flip side of the access crisis. It's rising healthcare costs that are pushing health insurance out of reach for increasing numbers of Americans. It's an issue that I care very deeply about, and it's been the subject of many of my other previous films. In 2008, when the Affordable Care Act was being debated, the focus of our reporting was on the access crisis. Our perception and reading of the tea leaves was that 2012, another election year, was going to be a year in which we were going to scrutinize healthcare costs, and the focus seems to have shifted. But if we can get a handle on costs, it'll certainly enable us to afford coverage for many, many millions of more people. The estimate was in the film that $800 billion could somehow be saved if you could eliminate unnecessary healthcare procedures. Now, that's a lot more easily said than done, and I realize that's rather glib, but that's another way of attacking the health access crisis that I care deeply about.
I just wanted one follow-up. Are you interested in reading the tea leaves on what the Supreme Court will
That's one thing. The question is the rulings of the Supreme Court, this is a personal belief, but I think it has some good foundation. For Intermountain, it won't make a bit of difference in the world.
It won't make?
Won't make a bit of difference in the entire world. The reason is not just us. I helped organize something some years ago called the High Value Healthcare Collaborative. It's 18 large integrated delivery systems. We're about 10% of the care in the country. If we added the rest of the integrated systems, we'd be up to about 20%. We're already so far down the path to dealing with this appropriately from within the professions, within the industry. There's no turning back. And it's accelerating rapidly. It will potentially create political turmoil over here. It could slow us down if it got too nasty. But I think in terms of the direction and the speed of it, I personally just don't think there's any turning back, and it's a really good thing. Care is going to become much, much better over the next 10 years than it's been in the past across the country.
How does what you're doing there, though, for instance, deal with patients who have insurance, who don't have insurance, or does it not matter the way that you approach it?
Two things you need to hear. Intermountain supplies about almost 60% of all care in our region of the country. We're a charitable not-for-profit who actually behaves like a charitable not-for-profit. The way that we say it is the best medical result at the lowest necessary cost, because we understand that health care costs innately limit access to care, and will continue to do so in the future. So we've been working on that for a long, long time. Each year we'll do about $300 million in free care. So when you come to us, we don't care if you have insurance. We're going to care for you anyway. And then you try to kind of make ends meet on the backside. Just two other fun little statistics that help inform the debate. The first, you do understand that the uninsured in the United States consume more healthcare resources per person per year for the uninsured than is spent on average on citizens of many European countries. So the fact that you don't have insurance doesn't mean that you don't have care. The problem is people tend to delay their care. And they delay it until it's more advanced disease, worse outcomes, higher costs. And the real trick with this is to get people in early, get them into good primary care programs. So the next thing you need to know, a question, what's the single biggest factor that will determine your health as an individual, how long and how well you live? It's your health behaviors. Best research shows that your own personal behaviors account for about 42% of your total health. About 30%, the old joke is how wise you were in selecting your parents. It's genetics. We don't have any major interventions for that. About 25% of how long and how well you live is public health. Primarily control of epidemic infectious disease through sanitation and immunization. At best, healthcare delivery, this massive system of which we're a part, are 3 to 7% of your total health. So we work at the margin. You see, one of the scary things about our current course, at least in Utah where we could see it clearly, the impact of extending insurance is going to increase the proportion of the Utah state budget going to Medicaid from about 18% of the state budget to something approaching 40%. There is only one potential source for those dollars. That's K-12 education. Education of our children. Interesting thing on the behavioral side, the primary predictor of good health behavior is your education level. There's a series of good studies that demonstrate you can achieve a bigger health effect by investing in general education. More high school graduates, more college graduates will have a bigger effect on the health of a population than investing the same money in healthcare delivery. So you heard the term in the film, we call it rescue care. But rescue care is when you're close to the end anyway, you're walking that line. And that's where the money goes, is into rescue care. As opposed to the far more effective things that you can do up front and early. So my question is what's your real goal? What's your real interest? Is your interest health? You'd invest your dollars differently than if your interest is in selling some hope for people who are already marginal. in terms of their current health status. You see?
All the way in the back there. Yes.
Hi, I want to ask or have you elaborate a little bit more on the notion of collaborative systems in the hospital between various doctors working together to form sort of a team environment in the hospitals. I was wondering if that's a sort of innovation that you guys came up with at Intermountain, where those ideas came from, because they seem to be really powerful in fostering the kind of system that you guys are working on setting up.
I think everybody heard it, but the question is asking you to comment on this idea of collaboration between doctors in different areas in the hospital.
Our history at Intermountain really had two seminal events. The first was in 1986. We were one of the first groups to examine care delivery in the same facility for very carefully balanced patients. So far as we could tell, were identical coming in, identical going out. And we discovered massive variation from physician to physician in how that care was delivered. Variation that was so great that just on the face of it, it was pretty much physically impossible that everybody could be getting good care. We fed the data back to the physicians involved, the nursing teams, and you suddenly realize that one of your colleagues, somebody you respected, you saw them on rounds every day, right? They were doing it differently and appeared to be getting a good result. The upshot of that is the variation declined. And as we watched the variation drop, our medical outcomes improved. Measured medical outcomes improved rather dramatically, and costs fell. Now, bumped into a fellow named Deming, W. Edwards Deming, who had theory that described what we were seeing. The next seminal breakthrough happened in 1991. A guy named Alan Morris in our shock trauma respiratory ICU, a big level 1 trauma unit, at our one of our academic medical centers at the time, LDS Hospital, now Intermountain Medical Center, the hospital you saw we upgraded some years ago. He was studying a condition called acute respiratory distress syndrome, deadly disease. For ECMO entry criteria patients, there's some jargon for you. Less than 1 in 10 patients live through this thing. And we were looking at how we managed ventilators. This is where we were able to show significant variation. Same physician, same patient, literally morning to night rounds. Massive variation. He developed a technique. It's based upon, for those of you into quality theory, something called lean, called mass customization, where you establish an evidence-based best practice protocol. Best evidence you can find. Now, interestingly, this has all sorts of troubles. I can find evidence for best therapy about 15 to 20% of the time on average. All right? 80 or 85% of the time, there is no evidence about best therapy. It's based upon tradition, experience, recall. But we just said, let's standardize it. I can demonstrate scientifically that when I build one of these protocols, I can't build a protocol that perfectly fits any patient. Humans who come to me for care are too variable, too different. Any physician recognizes that innately. Therefore, the way I say it to my colleagues, it's not just that we allow or even that we encourage. We demand that you modify our evidence-based best practice protocol based upon the needs of the individual in front of you. When we did that, variation dropped dramatically. Well, in Alan's ARDS trial, survival increased from 9.5% to 44% in the context of a big randomized controlled trial. First time since that syndrome was defined as a syndrome back in the 60s that anybody had shown an improvement in clinical outcomes. So it dropped our cost of care from about $160,000 per case to about $120,000 per case, and we generalized the method. Today at Intermountain, I have about 60 of those protocols running under measurement. You got to track the variations and track the patient outcomes. And then you feed the data back. It's called a learning system. Let me just say it this way. I can point to literally thousands of lives per year. People who a few years ago would have died who don't today. We count our successes in lives, literally. It's associated with hundreds of millions of dollars of savings for the people of the state of Utah, mostly. And it's not just us by a long shot. The funny thing is the UCLA crowd, they're partners with us in this now. Dr. Feinberg and quite a number of other. Now, what it takes is that kind of an environment. And so when I talk about teams, that's what I mean. I mean a coordinated teams of physicians and nurses backed up by a decent data system so you can see what's happening. And at that point, I don't have to monitor them particularly. I don't have to motivate them. I just have to let the medical profession have its head and change happens.
Trying to see over here, just because I can't see over here, so I'll go over here.
Thank you. I was surprised, Brent, that you, in describing the various costs in the system, didn't at all talk about the meaningfulness of socioeconomic differences. So it's fascinating to me in this film that UCLA actually treated a few African Americans, but I didn't see any at Intermountain.
No.
Now that's a proxy, I would argue, on some level for socioeconomic status, and I do think it contributes probably 40 or 45% in healthcare costs. Now, in addition, one of the things that I thought was lacking in the film is any discussion of health insurance. If we want to get more efficient in this system, save money, evidence shows us that if we got rid of the multi-payer, private health insurance industry in this country and moved towards a Medicare for all type system or single payer system, we could save again billions of dollars, $400, $500 billion by that maneuver alone. So I was disappointed that wasn't in the film. And finally, one last comment. The tragedy, of course, is that Dr. Brown died about a month ago, as many of you know, from a cerebral hemorrhage in Louisville, Kentucky. And, the question of the effectiveness, frankly, of his having had these coils placed is one that could be raised. Should he have, in fact, had that aneurysm clipped or operated on? Any points?
Yes, these are all actually just comments, but I'm sure there are things that you both sort of want to address. One of which I would have asked you too, the old socioeconomic issue and the idea of, is it different when there's more of a homogenous community than when there is not? And also the idea, which you talked about a little bit more, about addressing, health insurance, but.
So why don't I deal with the first one first, Roger, then you go second on it. It turns out that on average, Utah, in terms of ethnic minorities, is about average for the country. Our ethnic minorities tend not to be African Americans. We've got a relatively small African American population. Our biggest ethnic minorities are Hispanic, American natives, interestingly, East Asians, and Pacific Islanders. But we're about average in terms of the proportion. If anything, Utah's overall socioeconomic rate's a little bit lower. Our population is younger. We have a relatively young population from a high birth rate. At least the Dartmouth folks take those out in the analyses. Here's the funny thing, though. You get four things together. Healthy behaviors are that's the biggest driver of health in a population, are tightly tied to education levels. Education levels are just as tightly tied to socioeconomic levels. In fact, they're so tightly tied that they're almost inseparable. And of course, the last element of the four that you get in this little mix is insurance rates. And then you have to look at the four and decide how you'd make an intervention within that. I personally believe that one of the best things we can do is education. And that's not something the healing professions are particularly well organized to do, frankly. It requires partnerships with schools or with other community organizations or government of some sort. But they're very tightly tied together where it's almost impossible to pick them apart, you see. But yeah.
You didn't mention socioeconomic status.
Yeah. Well, it turns out that the Dartmouth Health Atlas studies that measure variation across the country control for socioeconomic status, and their contention is that the variation is more attributable to capacity or supply than socioeconomic status. That is, a community that has more hospital beds will have patients spending more time in the hospital. A community that has more ICU beds, likewise, will have more patients spending more time in the ICU. What's really fascinating is there's a study comparing San Francisco and Los Angeles. Both UC health systems, both great academic medical centers, and your chances of dying in the ICU in Los Angeles were significantly greater than dying in the ICU in San Francisco. And on down the line, whether it was diagnostic imaging or doctor visits, it had to do with the available supply or capacity, what the Dartmouth Health Atlas people call supply-sensitive care. Having said that, I do think that it plays a role in the variation, but just not the dominant role. And then to address your broader question about health insurance reform, something that's near and dear to my heart, it just comes back to that same contention that one can only wrap one's arms around so much in 80 minutes. And we devoted an entire film to looking at lessons we could learn from Canada's single-payer healthcare system in a previous film, and in Critical Condition looked at the struggles of the uninsured exclusively. This time we wanted to look and try to do justice in such a short amount of time to some of the drivers of healthcare costs and how we could get our hands around those and control rising healthcare costs, because that is what is going to make it so much more difficult to cover the uninsured, the unsustainable growth in healthcare spending.
Yes.
Just a quick anecdote and then a question. A friend of mine, also a physician, made the comment that having excellent medical insurance was a risk factor. This was because of the fact that he'd observed that the better your health care insurance, the more unnecessary testing and unnecessary treatment you had. Now, with that in mind, until we dissociate the profit motive from the delivery of health care, how are we ever going to really make a difference in the cost of health care or the quality of health care, no matter what the Supreme Court does about the Affordable Health Care Act?
So, well, it's an interesting question. Yeah, until we, how does anything make a difference until we disassociate the idea of the profit margin, which, it's devoted a little bit of time is discussed in the film about this. But yeah, but you go. You're about to. You're chomping at the bit.
The reason I am is I have to slip out of here and catch an airplane back to Washington for my Institute of Medicine meeting. So
Okay, then let's go.
we're the first ones who stumbled upon this. Reed Abelson published on the front page of the Times a few years ago and kicked off what's called the Pay for Performance movement. About 3/4 of the time when we improved care and reduced the cost of care, we were financially punished. The reason is under the fee-for-service system, I'm paid more to do more, even if it's unnecessary. I'm actually paid more when I harm patients with preventable complications. If we get off on that side of the whole thing, it's just absolutely perverse. As malaligned as it could possibly be, to the extent that payment systems represent social values, which in theory they should. This is completely immoral. Well, yeah, when you look at the whole thing, I believe that one of the most important things we can do is scrap the fee-for-service payment system. It's interesting, the physicians who are involved, they're not consciously practicing unethical medicine by any stretch. It's just sitting there in the background, you see. And suddenly you find that all the forces align. They all line up in a row. I'm pretty aggressive anyway in wanting to treat. I've got a real bias toward action. Society says that's valuable. They pay me more when I do that. That university professor that you saw who said, well, it doesn't change what I'm paid. My trouble is I have university appointments too. I'm enamored of the technology. I love that technology. It's fun at one level. It really is. And I learned back when I was in residency, we had the fellow who probably did more breast cancer surgery than anyone else in our region. Good surgeon. And what you came to understand, that he was in a lifelong battle with a deadly, terrible monster, a deadly disease, breast cancer. And in a very real sense, to Dr. Wilson, the patient was merely the battleground upon which we fought. And frankly, sometimes in a pitched battle, the battleground kind of gets chewed up. And he was a good, caring man. But on the other hand, he took a message away from that, you see. Now, I said something in there that I fundamentally believe. If I don't have a surgeon, a proceduralist who honestly believes in what they're doing, I don't want them touching me. And the reason is you just won't be good to the level that you ought to be. You see? Funny thing, to illustrate it again, a few years ago we did a big study of spine surgery for mechanical low back pain. We discovered it was a relatively bad operation, at least in Utah. About a third of the people who got that operation actively came out worse. About a third of them, no change. About a third of them got better. It's not a good operation. But in among these folks, we had one surgeon, Reed Fogg, at the Intermountain Spine Institute, who was head and shoulders better than everybody else in terms of his long-term patient outcomes. I know Reed, he's a good surgeon, but he's not that good. And then you examined his actual process of care. What you saw was two men in front of him in this particular case, Warren Statler, Terry Sawchuk. They're called physiatrists. They're non-surgeons who specialize in musculoskeletal injury, in back pain. What happened, Warren and Terry were screening all the patients and pumping on to Reed the good surgical candidates. And the key is don't let Reed choose them, let Warren and Terry choose them. You see what I mean? And then you had a fairly gifted surgeon who went on to have great results because he was working on the people who had a real benefit.
Well, I just, and I think Dr. James could comment even further on it, and that is there are a lot of exciting experiments with alternative financing systems, accountable care organizations, bundled payments, ways of changing the incentives, the fundamental incentives of fee-for-service. And I think those things are taking off. And I think regardless of what happens with the Affordable Care Act, those innovations will grow, right?
That is exactly right. That's where most of my life is spent these days. 4 years ago, Intermountain made a decision to shift into, there are a number of names for it. The ugly one is capitation. We think that in 20 years, our measurement system has improved to the point where we can demonstrate high quality, that you're not withholding necessary care. And we think the right thing is to remove those financial incentives or align them to good care, and we think the right way to do that is capitation. So Intermountain as a system is moving heavily toward full capitated premium-based care, where the managed care organization is run by the physicians and nurses at the bedside, not by some third-party insurer. By the way, I have real problems with for-profit insurance. I'm not sure it's as much a solution as we may think, but I agree with you in your basic assessment.
Do you have time for another question or two, Doctor?
Maybe one more, and then I better run.
Okay, let's do it. And there it is.
Doctor, you mentioned that 42% of medical costs is associated with individual behavior.
42% of how long and how well you live, to be technically correct.
Are there steps that you are taking to help people modify their behavior?
There sure are. They fall into two major categories. Just one example among a list, it's called HotSpotting. We have tools from David Eddy, the father of evidence-based medicine, to much more accurately estimate potential benefit from early preventive interventions at a population level, and we're deploying them. It means I can much better pick out who will benefit from a statin to lower your blood cholesterol, right, or other similar interventions. It's got a beautiful representation where if you were to come see us, we'd sit you down, assess you fairly quickly and easily, and then we could say, well, if you got your weight down, if you got your exercise rates up, if you took that statin, if we controlled your blood pressure, here's the impact it would have on your life expectancy. So that's one method. Another thing that we're doing is partnering much more closely with other institutions, schools particularly, religious organizations, other community-based, local, state government organizations. We think we can change some of these things. The aim is to reduce the need for rescue care, reduce the need for health care. The best care is care you never need. You do understand?
Well, I just want to, I want to thank both of you for being here. Yes. And Roger, I just want to say thank you so much for letting us see this film. And I also, having seen many of your other films, the idea that you do just focus on this one issue, now people can go find his other films about other parts of the healthcare debate, I think is really kind of genius, so that we can focus on that and then also ask the other questions. So we look forward to seeing this on TV.
Fortunately, there are lots of issues
yes,
left
and
to address.
unfortunately, there are lots of issues left. But thank you very, very much. Thank you, both of you. And thank all of you for being here.